So the drugs which are example of these are dobutamine. I told you it is a beta 1 agonist. We have seen it earlier, and it causes action beta 1 more prominently. It also causes beta 2 and alpha 1. It has got strong inotropic effect and relatively weak chronotropic effect. That means it causes increase in force of contraction more comparatively than the rate of heart rate. It doesn't increase heart rate too much. There are no significant changes in BP because it is alpha 1 agonist also and beta 2 also, and there is a balance between these two. Its use is problematic in patients who take beta blockers, due to which its adrenergic properties they will be modified. So this is the problem with the dobutamine. The next drug in that class is amilrinone. The previously there was one more drug was there, that was known amrinone, milrinone. These are the drugs. They are inhibiting the phosphodiesterase 3. Now this is again very interesting. You should understand how it is there. If you remember the second messenger mechanism, that the drugs are there, they causes stimulation of G protein coupled receptor, and because of that there is activation of cyclic AMP. So this is how the second drug, this is milrinone, that is acting. It is an ionodilator. That means it causes the increase in the cardiac contractility and reducing the afterload. It reduces the afterload, and because of that, reduction in the left ventricular filling pressure. So because of that, the impact of milrinone will be there. Then this PKA, that is protein kinase A, increases the contractility of the left ventricular and cardiac output through cyclic AMP dependent kinases. So this is how this milrinone is acting. What are the impacts it is causing? It causes less myocardial oxygen consumption with milrinone when compared with the dobutamine. So this is a benefit, because many times oxygen consumption is another concern. It can use in combination with beta blocker. Dobutamine cannot be used along with the beta blockers because it acts as a beta agonist. So you cannot simultaneously give beta agonist and beta 1 agonist and beta 1 agonist and beta 1 antagonist. The effects are not dependent on beta adrenal receptors. Therefore, milrinone does not require it. It is not only act as a systemic but also as a pulmonary vasodilator. It is additional benefit it is having, and it is preferred agent in the patient with pulmonary hypertension and this heart failure. Both are simultaneously there. So most of the hemodynamic effect of dobutamine and milrinone are same. There is an increase in the cardiac output, and it causes peripheral vasodilation. It causes decrease in the pulmonary capillary wedge pressure. So these are the effects it is having, and thus it gives benefit to the patient. But what are the differences in these two, dobutamine and milrinone? The dobutamine causes greater increase in heart rate, while milrinone causes more hypotension. Rather, it is beneficial again. There is a dobutamine causes greater increase in myocardial oxygen consumption. Milrinone causes greater reduction in the left and right filling pressures. Dobutamine is having pro-arrhythmic effect, including ventricular tachycardia. It causes mean arterial blood pressure and pulmonary arterial pressure. Okay. The effect are attenuated in the patient who receive beta blockers, because both, as I told you, beta blocker and dobutamine is beta agonist. Greater hemodynamic effect when patients are on beta blockers. So it is a synergistic effect they are having. Dobutamine is less expensive while milrinone is more expensive, and milrinone is having longer duration of action after discontinuation, particularly in renal dysfunction, because it is excreted through kidneys. So in that cases, care has to be taken. So these are activity. Uh, uh, Actually, inotropic mortality, there is no big meaning for that, because most of the time when inotropic agent has to be given, that means the patient is in the very higher stage of heart failure, and it is just effort to prolong the life. So still it is there, mortalities are there, and it cannot reduce mortalities that way, only it can extend it. That are the benefit. So these are various activities, these are the various things which are there. I will not go in detail for other treatment activities, and transplantation will not go for. So this is how the drugs are working. These are various drugs. Now tomorrow we shall go for the what we can say, digitalis and other such drugs which are important. In the meanwhile, you can I'll just let you know brief information about this, that is how the drugs are there, how drug can be used into it. So here and how various drugs are acting. So this will help you to make it in better way. So we have got two important situations during heart failure. These two important situations are, we call it as a diastolic failure and systolic failure. So what happens during that? During systolic failure, what are the mechanism, pathophysiologic taking place, and what we will be doing? Systolic failure means difficulty in the contractions, while diastolic means the heart size is increasing, and that is resulting into changes. So this systolic heart is there, where cardiac output has reduced. Why it has reduced? Because of many reasons. It is a cyclic process, so one after another it is happening. So cardiac output reduced, because of that blood pressure and the organ perfusion has reduced. Because of this decrease in that, the renin-angiotensin activities, this can be initiated. The natriuretic peptides and atrial and brain natriuretic peptides, they will be increased. But here the problem is the neprilysin will cause problem, and the renal perfusion, natriuretic acid diuresis will be there, it should be there, but it will decrease. So what we have to do in that case, we can use diuretics, or we have to support it with ARNIs, which will improve it. Then they will cause inhibition on vasoconstriction afterload and preload, particularly through renin-angiotensin mechanism. So this renin-angiotensin mechanism, they are inhibiting both, that is sympathetic nervous system, RAS, vasopressin. These all are causing decrease in the renal problem, that is increase in the this accumulation. Then sodium accumulation, water accumulation, therefore increase in the vasoconstriction, afterload, preload. These are the effects which are there because of this. And these are renin-angiotensin mechanism are there. They are inhibiting, renin-angiotensin is inhibiting these beneficial effects and causing the detrimental or disastrous effects, while this is inhibiting this disastrous effect and causing the benefit effect. So we have got diuretics which can be blocking this vasoconstriction, afterload, preload. These beneficial activities are there, so we can improve this. Then we can have vasodilators which can give benefit in preload and afterload. So this from that, because of the vasoconstriction, increase in preload, increase in afterload, that causes further decrease of the cardiac output, because it affects cardiac. So vasodilator will be affecting this, and thus it will protect it from that. Then there will be increase in the heart rate and force of contraction, increase in the blood pressure, again because of this sympathetic mechanism. And this will again make impact on cardiac output, and it will initially increase it, but over the time it will affect it. Then because of this sympathetic and renin-angiotensin mechanism, that what it will be causing is, it will causing the hypertrophy of heart cardiac muscles, it will cause cell death, it will cause fibrosis, it will cause arrhythmias. They are again detrimental, and they will cause increase in the problem, and therefore more decrease in the cardiac output, and again this cycle will be continued. So this is how this cycle is working, and thus we have got various drugs which are taking part, which are useful in these activities. Then another situation is there, that is how the diastolic heart failure takes place, and it is because of various pre-existing problems. That is, hypertension will cause increase in the preload, increase in the afterload. Then there are diabetes is there, it will cause oxidative stress and oxidation, this various reactive oxygen species activation will be there. Then coronary artery diseases or microvessel problems will be there, it will produce ischemia. Then obesity will be there, it will produce overload. These all various reasons are there that will cause hypertrophy of the cardiomyocyte. I told you what is hypertrophy. Hypertrophy means a sort of growth. If you remember pathophysiology, in pathophysiology you might have studied the injury and tissue repair process. So during tissue repair process, what happens, that there are natural repair mechanism, and another one is called as a fibrosis. Fibrosis means, or scar tissue formation. So what happens in scar tissue? Scar tissue is a tissue which is not having functional, it does not show same function. Similarly, what will happen is, because of the overload in hypertension or oxidative stress in the these are the various causative factors, and these causative factors will cause injury to cardiomyocytes, and this injury, for that there will be a repair mechanism, but this repair mechanism will be not a normal mechanism. Instead of that, fibrous tissue will be formed. So there will be cells, but these cells are not functioning as a cardiomyocytes. They will be they will not take part in a contraction as similar. So what are the problem? Because of that, if it is not contracting as such, then there is no function, or there is a decrease in the function. It will make obstruction in the function of cardiac. It will share same nutrient which are there for cardiomyocytes, है ना. जो cardiomyocytes को nutrient मिलना चाहिए, because they are contracting, they are relaxing, their contraction relaxation, they are pumping, but these agents are not pumping and still they are receiving nutrients, so they are sharing it. Then they are participating in the stiffening activity. Okay, titin proteins are there, and therefore it causes stiffening of it, and this fibrosis is there. So because of that, the size of heart increases. So this is what we call as a diastolic heart failure. Because of the increase in the size, but not function, rather decrease in the function. The size increases, function decreases, and because of that it causes diastolic relaxation defect. It will not be properly relaxed, so it will reduce the reserves in that, and because of that it will cause pulmonary congestion, peripheral congestion, and decrease in the cardiac output. So for that, what are the drugs which can use? We can use ARB inhibitors, CCBs, diuretic beta blocker, or this various mineralocorticoid receptor antagonists for treatment or treatment of diabetes, CADs, obesity. CAD we have seen, coronary artery disease means angina treatment we have seen. So all these treatments are done so that we are taking care of. These are the secondary causes: hypertension, diabetes, coronary artery diseases. So we have to see that we have to take care of the secondary actions. Then we are giving aldosterone, that is mineralocorticoid receptor antagonist. Then phosphodiesterase 5 inhibitors. So I was telling about these 5 phosphodiesterase inhibitors. You know about this cyclic AMP is a second messenger, cyclic GMP is a second messenger, and these messengers are metabolized by phosphodiesterases. So there are many varieties of phosphodiesterases are present. Simply what they are doing, suppose the drug is acting on G protein coupled receptor, this G protein coupled receptor has causes the activation of cyclic AMP. So this cyclic AMP is formed because of the adenylate cyclase enzyme was there. So because of the activation of adenylate cyclase, cyclic AMP was formed. Cyclic AMP is there, Now this cyclic AMP is acting, or it's causing the action on the protein kinases, and this is how it is causing its action. Now this cyclic AMP is metabolized immediately by phosphodiesterase 5 inhibitor, phosphodiesterase 5 enzyme. So phosphodiesterase, this is the enzyme, so it will break down the cyclic AMP phosphate, and thus it will not remain active. So if we have got inhibitors, so instead of causing G protein coupled receptor activation, what we can do is we can do this phosphodiesterase inhibition, and because of that it will do it. Then guanylyl cyclase activated, that means nitrates. Okay, these are the guanylyl cyclase activators. Then ARNI, ARNIs we have seen, that is neprilysin inhibitors. So these are various drugs which can be used, and thus these drugs, because natriuretic peptides are very useful in preventing this hypertrophy. So we can use either natriuretic peptide drug as such, or we can give the drugs which will inhibit the metabolism of natriuretic peptides. So we have seen these drugs just recently, and accordingly we have got variety of such drugs which will be useful, which will be acting at various levels. So this is again good figure which will be helpful in your therapeutics, various stages and various treatments in various stages, what are the goals and what are the drugs and what are the care. This is simple table, it is there. This is we are not considering in pharmacology now, because it is, as I told you, it is a therapeutic portion. Now next thing is various drugs acting at other various levels. So let me explain you. Okay, we will go for this figure. This is catecholamine, we have seen, these are the catecholamines. So they are acting on beta 1 adrenergic receptor. This is action, so cyclic AMP, there cyclic AMP is activated. So here it is a phosphodiesterase 3, we have got PD inhibitor, that is phosphodiesterase inhibitor. We have seen amrinone, milrinone, these are the agents which are acting, and this is because of that cyclic AMP is having more action on the protein kinases, and because of that it is acting on calcium. Calcium will be activated, and this causes more calcium from the sarcoplasmic reticulum. It will increase the intracellular calcium level, and because of that there is a actin, myosin filaments, troponin, etc., and this will be acting, causing contraction. So this is the mechanism which is taking place. Then how we can have variety of drugs which are acting. We will see the digitalis mechanism in brief. So there is always, what happen is the calcium which is there intracellular, that is thrown out of the cell, and the 3 sodiums are coming it, and when these 3 sodium are always exchanged with the potassium. So this is a continuous regulation of ions. So these calcium ATPases are there, they are causing removal of calcium. This removal of calcium is simultaneously occurring. Then there is a contrast ports, or we call it as a antiport. So this antiport will cause 3 sodium in and 1 calcium out. So this 3 sodium will be, but this 3 sodium has to go out. If this 3 sodium remain there, then it will, this pump will not be working. So this sodium has to go out, and it will bring in 2 potassium. This is called as a sodium potassium pump. Okay, so 3 sodium will go out, 2 potassium will come in, and here this is the place where the cardiac glycoside, that is digoxin, is acting. Because of that it inhibits this portion, and because of that sodium potassium ATPase, this is a sodium potassium and this is sodium calcium exchanger, okay, or antiport. So this sodium potassium calcium exchanger is there, and here it is a sodium potassium antiport we have got. So sodium potassium ATPase antiport is there, that is 3 sodium goes out, sodium, this is inhibited because of the drug, and accordingly because of this inhibition here the sodium will not go out, so sodium will accumulate. If sodium accumulates, then this pump will not able to function, because of the more sodium, this sodium cannot come in. If this sodium cannot come in, then calcium will be calcium will be remaining over there. Now because of that, what is happening, you can understand, you can imagine, if this is blocked, that means potassium cannot come in. If the potassium cannot come in, that means it will remain in extracellular fluid. From extracellular fluid it can go to blood, from blood it can get excreted, and because of that this can cause decrease in the potassium level, that is called as a hypokalemia. And if this level is decreased, then if the potassium is less available, then still it will affect this pump more. If this pump is affected more, then still the calcium will remain more. Okay. Now if the calcium is remaining over here, then what is the role calcium will be doing? This calcium will cause what? This calcium will be participating in the increase in the intracellular calcium, that will cause stimulation of the ryanodine receptor. This ryanodine receptor will cause release of calcium from the sarcoplasmic reticulum calcium channels. Okay, and this calcium will be binding. So mind well, this calcium which is coming from extracellular is not binding, but this will be binding, and these are the calcium sensitizers which are there. So because of that, it takes place in the muscle contraction. So because of that, calcium is accumulated, and the contraction, heart will be in a contracted position. Therefore the digitalis is also called as a cardiotonic. Why it is called as a cardiotonic? Because it increases the tone of heart. Just like skeletal muscle, we have seen skeletal muscle tone increase, isn't it? We have seen in what cases? In myasthenia gravis, if you remember. So this is how the drugs are acting, and this is the effect of the drugs which are there. So this is the mechanism of action. Go through this, how these drugs are acting, and then we can go for few more details about the digitalis. So this is how digitalis is there, and once we complete the digitalis, then we will complete almost heart failure. So take care, be safe, and be cautious.